Hello, everybody. I'm Bob Levine. I'm a periodontist in Philadelphia. I want to welcome you to our third AO Hot Seat. My co-host tonight is Briar Voy, P3, Price Resident, University of Pennsylvania. And our special guest is Bob Vogel. I'm going to first introduce you, Bob. Bob graduated from Columbia University in New York before completing residency training at Jackson Memorial, Mount Sinai, and Miami Children's Hospital in Miami, Florida. He maintains a private practice in Palm Beach Gardens, Florida, limited to implant pros and reconstructive dentistry, working as a team member with several specialists, providing implant-based treatment, conducting clinical trials, as well as providing advice to the dental attachment and implant field. Bob has developed and collaborated on the development of several prosthetic components currently in use in implant dentistry. He speaks in the US and internationally 45 weeks a year on implant dentistry, focused on precision and predictability through ideal planning, use of digital technologies, and team interaction. He's published over 40 scientific papers, is a fellow of the International Team for Implantology, a diplomate and vice president of the board of the Academy of Osseointegration, and fellow of the International College of Dentists. My first question, Bob, please review your professional life and how you have gotten to this present role of, in leadership and our future president in the Academy of Osseointegration.
Well, thanks for the introduction, Bob. Hi, Briar. Sorry we got a late start, technical glitch, but I guess we're up and running now. So when I got out of my residency training, I went into private practice, and there was a specialist in town who, in my first year in private practice, who invited me to go to an AO meeting. And I actually didn't know what AO was, but I went to Chicago for a meeting with him, and I was blown away. I mean, really blown away. Here were presentations from people, you'd read about, you've heard the names of, and they were presented, and it wasn't anecdotal information. It was scientific information, but presented in a way that you could take it home Monday and use it in your practice. And I'm thinking, this is incredible, just great information. So the next day, I'm in the exhibit hall at the AO meeting, sitting there having lunch, and Dennis Tarnow sits down at my table, and I'm like, this is the guy, amazing. So the beauty of what I realized with AO right away was you have accessibility to all these world-renowned speakers in a very casual, friendly atmosphere, and then in the hallway, in the lecture rooms. And every time I went back to an AO meeting after that, I saw the same people. We became friendly, and you have a network of similar thinking people. So I joined a committee on AO, just thought it would be fun to do. And over the years, just kept working with AO, and here I am. I'm going to be president next year.
So first, let's talk a little bit about what some of the risks are with using removable prostheses in implant dentistry, because we know they're kind of known as the black sheep of the prosthetic family. Can you tell us a little bit more about why we should be considering them and what has made them into the black sheep of implant dentistry, if you see those complications too, or if you agree?
So that's a great question. And the reason it's a great question is because everybody's kind of down on overdentures. And they say, oh, there's complications, and there's implant loss, and there's so many issues that everything needs to be a fixed restoration. But the reality is that the complications we see, and this is well documented, and we see articles written on complications. Obviously, it's well documented that the complications we see, and the reason they get a bad reputation, is because of things that we're doing wrong, that we're not doing properly. And the main thing to understand when we talk about why they get a bad reputation, the main thing to understand is that when we look at an overdenture, so on the right-hand side of the screen is a maxillary overdenture, and we compare that to a fixed restoration on the left-hand side of the screen, you see a hybrid. The main difference to understand, and this is the most critical starting point, is that in a hybrid restoration is an implant-supported restoration. It's screwed down and supported by the implants. When we talk about an overdenture, that's not an implant-supported denture. And I hear people say this all the time, oh, we made an implant-supported supported denture. No, it should be an implant retained tissue supported denture. And that's the critical factor. So if we've got 4 individual implants, or in the mandible, 2, 3, or 4 implants, and that denture is being supported by those implants, then every time that patient bites down, we're just putting excessive lateral forces on there. And because the implants aren't splinted, we have no control over those forces. So the critical factor that we need to consider first before anything is that it's implant retained tissue supported. And the way I achieve that successfully, very successfully, is I always cure my housings chair side. When we're talking about not a bar, not an overdenture bar, but when we're talking about single non-splinted implants, I cure my housings chair side with the patient biting down with a little bit of mucocompression to ensure that we have contact with an intimate contact between the intaglio surface and the underlying tissues. That's probably the biggest. Then you asked about failures, and the reason, if we get past that part, the second reason why we see failures are one of the basic premises of overdentures, and I'm showing maxillary overdentures because we have much fewer complications in the mandible, much more forgiving in the mandible. But in the maxilla, one of the biggest complications is actually poor implant placement. And if you look at this photograph in the center of the screen, the second factor, other than being tissue supported, the second factor is when we have implants with significant angulation, I'd say more than about 20, 25, let's say more than 25-degree angulation. And if we have inadequate buccal bone around those implants, they're almost doomed to fail with a removable appliance if they're not splinted. Of course, we can correct that by splinting them. So those would be our big factors. It has to be tissue supported, not implant supported. We've got to control the angulation. Malaligned implants, more than about 25 degrees, are a problem. And inadequate buccal bone, I'd say less than 2 millimeters of buccal bone. And if you put that together with a bruxer, like this guy you see on the lower left, somebody with parafunction, they're doomed to failure as solitary non-splinted implants.
Bob, let me suggest as a periodontist, the thickness of the soft tissue is very important. The width and the thickness of the keratinized mucosa on top.
Yeah.
Yeah. Get this right. You're saying that to make sure that it's tissue supported and that you have a tissue supported denture, to use like pressure indicating paste before you even attach the housings to make sure you have equal pressure everywhere?
Yeah, that's critical. And as a pros resident, of course, we won't ignore Bob's question about the soft tissue. Sorry about that.
You already did. I'm okay with that.
No, I think the lack of keratinized tissue is significant in terms of long-term maintenance, obviously, and reflects the bone underneath. But of course, the prosthetics are more important. So going to Briar's question about intimacy of fit between to make sure it's tissue supported. Yes, what I do is I put pressure indicating paste, whether this is a printed denture, a mill denture, or a processed denture, doesn't matter. I'm always going to put pressure indicating paste in there before I attach the housings, have the patient go into centric and make sure, as you're seeing on the upper right, that we do have contact with the soft tissue. And a lot of times what happens is we'll try it in before we put the housings in. It looks wonderful. Then when we put the housings in, the appliance is getting hung up vertically. It can't sit down on the housings, and we become implant supported. So it's critical to place your abutments, place your housings, and then try the appliance in with pressure indicating paste.
Great points.
Bob, anything else?
Yeah, actually, no, I think this.
Oh, actually, you know what?
I want to review this. Yeah.
Yeah. So I mentioned that the majority, probably 70% of the overdentures I make in my practice are mandibular. And these are patients that come in with a lower denture. The majority of these patients come in with a lower denture, and they have lack of retention. They have a flat ridge, so they're scooting all over the place, or when they lift their tongue up, the floor of the mouth displaces it. So the reason why so many of my overdentures are mandibular is that's the patients that's coming in is having those. And whether it's 2, 3, or 4 implants, which actually brings up another scenario when we talk about complications, which is, we always, and I don't know why, but we always put 2 implants in the cuspid position in the mandible, like you see on the lower left, which is not correct. And another complication that we see with 2 implants in
Can you explain that, Bob, about the cuspid position?
So,
that's important.
So what we're looking at, if you look at the lower left-hand picture, this was a case that I restored probably 20 years ago, and the implants were placed in the cuspid position, which is probably the greatest volume of bone, and that's why they were placed there. And that's what we always did. We always looked at 2 implants in the cuspid position. But now what we've come to realize, and there was a wonderful article published on this by Regina Stern out of Bern, Switzerland, and then Steve Sadowski also. But what we came to realize that if you place 2 implants in the mandible, which really should be the standard of care based on the McGill consensus from Jocelyn Fine, but if you place 2 implants in the cuspid position, we see a lot of anteroposterior. Remember, these are resilient attachments, so they allow rotation. We see a lot of anteroposterior tripping. So what we've decided to do in my practice over the last 10 years is, if we're only placing 2 implants in the mandible, we go closer to the lateral incisor position, and that will minimize some of that, a significant amount of the anteroposterior tripping. Or I'm a huge fan of the mandibular 3 implant overdenture, and the beauty of the mandibular 3 implant overdenture is it allows us to go further distal, usually just in front of the mental foramen, and then the 3rd implant, not right in the midline, but off the midline, and that will tremendously minimize our anteroposterior tripping as well. And it's funny because Briar and I were discussing this a while back about looking at ridge form, how important it is to look at ridge form. And if you look at the very bottom picture in the middle, when we've got a patient who's had a significant amount of horizontal hard and soft tissue loss, so this is a patient who's been a dentulous for many years, no teeth, no implants, they lose bone. So if there's a significant amount of horizontal hard and soft tissue loss, and we need to have that flange for lip support, if we've got 2 implants in the cuspid position, you're going to see anteroposterior tripping. That's why it's even more critical to look at that 3rd implant on those patients.
Is that what you're showing with that line?
Yeah, that I tried to outline the crest of the ridge. That red line is showing the crest of the ridge and how far anteriorly the mandibular anterior teeth are cantilevered off the crest of that ridge.
Yeah, that's a good point. And the reason you would go with 4 locators based on the discussion of the tripoding in the 3 versus the 2?
You know, I think the big difference with 4 is that it gives us greater retention. And you know, the difference between 3 and 4 might be minimal, but more importantly, the reason why we go with 4, and this is the most significant reason why we go with 4, is that can easily be transitioned to a hybrid, to a fixed case. And 40% of my overdentures transition to fixed cases within 2 years. So if we treatment plan for 4 up front and they're placed adequately, then and assuming we have the vertical space, then we can just go ahead and transition to a screw retained restoration or hybrid restoration.
Does that go for both jaws, Bob?
Yeah, without a doubt. Actually, I transition more maxillary overdentures to hybrids than mandibular overdentures to hybrids. The mandibular overdenture patients tend to be older patients. They're thrilled with the retention as opposed to a traditional denture. The maxillary patients, I present to them right up front what I call a transitional treatment plan. I present to them the option of the removable appliance, and I present to them the option of the fixed appliance. And usually for cost, they'll go with the removable, but within 2 years, they come back and want to do the fixed.
So what are the space requirements, Bob, for overdentures, bars, hybrid, crown and bridge? And how do you measure that vertical space requirement?
The second part of your question is terrific. The space requirement is one thing, but how do you measure it is critical, because if you look at the literature, you're going to see a wide range of numbers. And this always bothered me that there's a wide range of numbers. But what's critical is you have to look at from where are we measuring. So we're talking about restorative space. So we're strictly talking about restorative space. So when we talk about an overdenture with non-splinted implants, whether it's maxillary or mandibular an Ovidenture with non-splinted implants with either locators or Novalock, which is also a wonderful Ovidenture attachment, we only need a minimum of 8 millimeters of restorative space. So I'm measuring from the soft tissue to the occlusal surface of the tooth. The implant might be 1 millimeter below the tissue or 5 millimeters below the tissue. That doesn't enter into the measurement. The measurement is strictly from soft tissue to occlusal surface of the tooth. So 8 millimeters for non-splinted implants would be our minimum. When we add a bar, and I very rarely make a bar in the mandible, but almost 50% of my maxillary cases do get bars. When we make a bar, then we need 12 millimeters of restorative space, soft tissue to occlusal surface, because we need an additional 4 millimeters for that milled bar to fit underneath there. And then you could put attachments on that bar. A hybrid, traditional hybrid, now we're talking about 15 millimeters. And I know people are going to say, oh, I could do it in 14. Yeah, you can. But, you know, so 15 is from the soft tissue to the incisal edge. So if we look at Sarah, I'm measuring soft tissue to incisal edge is 15 millimeters, which tells us that a hybrid is not just replacing teeth. It's replacing, because nobody has a 15 millimeter, maybe a donkey has a 15 millimeter tooth, but it tells us we're replacing teeth and missing hard and soft tissue. So now knowing those numbers is critical, because when I do present that transitional treatment plan, if the patient is starting with an Ovidenture, I need to make sure I have adequate space to transition them to a hybrid if they decide to go that way.
Yeah, talking about pink porcelain or pink acrylic, could you define the FP1, FP2, FP3 and its relation to, you know, the pink porcelain, pink acrylic?
Yeah, so those, you know, those are relatively new terms. And so the FP, we're talking about fixed prosthesis type 1, fixed prosthesis type 2, fixed prosthesis type 3. And in the FP1, what we're talking about is just replacing teeth. So this is somebody who has not had a significant amount or any real periodontal bone loss. They have adequate bone all over the place. So we're just replacing teeth. And the FP1, most often when I do an FP1, which I do as many FP1s as I do hybrids. Those are segmental bridges. It's going to be, so if you look at Rose, who had no significant bone loss, vertical bone loss, she lost all her teeth either from advanced decay or fractured posts and cores and endos that failed. And she has a nice low lip, adequate lip support. She didn't need a flange. She had all the bone. So that would be our FP1. And there, really, we only need about 9-10 millimeters of space to restore that patient.
What are your ideal sites in this type of an FP1 where you're placing 6 implants, Bob?
My ideal would be first molar, first bi with a 3-unit bridge, first molar, first bi with a 3-unit bridge, and cuspid. Try to stay away from getting into the lateral sites or into never adjacent centrals. Way too hard to manage the pontic site.
Thank you.
So the FP2, now the FP2s, I'm not a huge fan of FP2s, but that's a patient who's missing teeth and soft tissue, maybe a little bit of bone as well. Obviously, if we're missing soft tissue, we're missing bone. So the FP2, which you see in the middle, we're replacing teeth and there's some pink porcelain there. The biggest thing you need to be aware of with an FP2, and I certainly make FP2s my practice, but the biggest thing is if you have a patient with a high smile line, so we're looking at Deidre on the lower left here with a high smile line, that patient's not a good candidate for an FP2 because you're going to see that transition line from real tissue to pink porcelain. So the FP2s, you're almost better off either doing a lot of grafting or going to an FP3. And the classic FP3 is our hybrid patient. So if we look at Paul, he's our classic. If you look how much bone loss, vertical bone loss he had, so he's missing maybe 9 millimeters of tooth plus another 5 millimeters of bone. We've got 14 millimeters of space there without a problem. So the FP3, you're replacing teeth and missing hard and soft tissue. That's it.
So what do you think would be the benefits of doing a removable prosthesis over these like great fixed alternatives?
Okay, so of course, there's a couple of factors. And if we look at the Academy of Osseointegration held a summit, 2016, held a summit discussing that. And then the international team, ITI, International Team for Implantology, published a treatment guide on it about 4 years ago, and both came up with pretty much the same conclusion, that a removable appliance is going to be less expensive. So if we're talking about something like this lower right for non-splinted implants, it is going to be more cost effective just because the lab bill is significantly less. Also, and much more importantly, with a removable appliance, you can replace a lot of missing hard and soft tissue, a lot of, replace flanges and lip support and facial support without compromising the access to hygiene. And that's really my primary determination in my practice when I look at a patient who's they're losing all their teeth to advanced periodontal disease and they haven't been able to manage their hygiene. What I'm looking at most importantly is, will they be able to maintain proper hygiene on a hybrid, on a fixed case? Otherwise, I'm pushing them to go removable, which is a lot easier to maintain hygienically. Okay. Of course, the other advantages, when the other big advantages, so those are our advantages, access to hygiene and cost. But the other advantage to removable, not even looking at fixed, but to removable alone, is that we're going to maintain bone. If patient has a denture, I have a lot of patients say, "Oh, I do fine with dentures." Well, you're doing fine with dentures in your 40s. How are you going to do in your 60s? So by placing implants, we're going to preserve bone. And then what came out of the McGill consensus that Jocelyn Fine published, and I mentioned it already because it's such a wonderful, study, is the psychosocial benefits and the systemic health benefits of implants under dentures, meaning edentulous people restrict what they do in their everyday activities based on their edentulosm. They don't go to a friend's house for dinner if they don't know what's going to be served. So having implants in there allow them more freedom in life. And then the systemic health benefits allow denture wearers who have implants placed under their dentures to eat better foods and different foods. And that's been, well, I don't want to waste too much time on it, but very well documented. So we're talking about cost effectiveness. Young, handsome dentist published just a couple of years ago showing the cost effectiveness of overdentures. And then we talk about the health benefits. Yeah, that was me. Yeah. I didn't want to go on, but yeah, I looked at strictly the cost effectiveness of overdentures, and it turns out that overdentures are cost effective. But more importantly, if you look right here, the overall health related quality of life was improved. So systemic health and as well as psychological health, and the cost effectiveness. Yes. That's that. Did you have anything else?
No, I think we're good on that.
So the quality of life issue. Actually, while I have this slide up here, because when we talk about overdentures, everybody thinks about the older patient. You think about the 80-year-old who comes in that's having trouble with their dentures. I've seen a rash of younger, Danielle's in her 30s, a rash of younger people that are fully edentulous, and they're coming in looking to get new dentures. I don't make traditional dentures in my practice anymore. They're looking to get new dentures or whiter dentures, and I talk to them about the quality of life issue. Are there things that you don't do because of your edentulism, and the importance of preserving the bone? So as an example, and Danielle wound up with 4 implants in the mandible. The reason being, going back to Bob's question, was that I knew she's going to want to transition to a hybrid down the road. She's in her 30s now. She's not going to live with an overdent forever. So we treatment planned her for 4. And interestingly enough, about 6 months after we delivered this, and she loved it. She was thrilled. 6 months after we delivered it, she came back. She had 4 implants placed in the maxilla, but she didn't want an overdenture in the maxilla. She went for a hybrid. She went for a fixed restoration in the maxilla. So, I look at overdentures as a gateway drug to fixed restoration in a younger patient. This is somebody that we've got to plan where those implants will be so that if they start as an overdenture, we can transition them to fixed down the road, which is exactly what Danielle did.
So on that point, when should we consider transitioning or converting a fixed case to a removable case? And how often have you done that in your practice? Like what percentage of the case?
So think about converting fixed to removable. The primary reason that I do it fairly often. The primary reason I'm going to convert fixed to removable is somebody who can't maintain this restoration hygienically. And I'm in somewhat of a unique situation being in South Florida because all of my patients have, they lived in the Northeast. They had implants placed when they were in their 50s or 60s, and they retire and they move to South Florida. And the problem is that a lot of the original, the older hybrids, and I'm not talking 20 years old, but a lot of these 8, 9, 10-year-old hybrids, patients come in, it was a cast metal frame with acrylic processed on that. Acrylic's the worst material we have in dentistry. It's full of porosity. It harbors all the bacteria. So I'm seeing situations like this picture, which I know is one of your favorite pictures, because there's so much going on here. And this is going to fail. So this is a patient that we're going to remove that fixed restoration. We're going to go to a removable restoration for hygiene. And you probably see other things in this picture that I don't even see, Bob.
I mean, there's a few things that I see. Obviously, lacking of keratinized mucosa, inflammation, different vertical heights, different position of implants buccolingually. So, the importance of using a surgical guide is very key. And also getting the prosthetic platforms on similar heights will make plaque control and maintenance much easier. So, yeah, there isn't anything good about this. So which are the implants that you see that fail? And I mean, this is a good example of why you would want to convert somebody who's just having problems, maintaining herself.
Yeah.
You see the distal implants fail in these situations?
Oh, yeah. Yeah. So I'll remove these. A patient will usually come in and we will see some separation around one of the implants, and I don't remove my hybrids at every recall visit. But if I see bleeding, separation or inflammation, then yes, I do remove it because I want to see what's going on, clean it out. So this patient had come in. She was complaining about pain in this area. When I pressed on the tissue, a little bit of pus came out of there. I said, I have to remove this without a doubt. Well, what happens quite often, and I'm not saying like, once a year, but maybe 8 or 9 times a year, is when I remove that hybrid, at least 1, if not 2 implants come with the hybrid. So those implants have already failed and they're just being held in by three remaining implants.
So you're saying in cases like that where you have implants that are failing and you know that the patient doesn't have great hygiene, instead of planning to place additional implants and do another fixed, you go ahead and you will convert them to removable. Is that like the EP spread, is that something that you're also considering when deciding removable and the cost benefit analysis of that?
When it comes to AP spread, yes, I'd like to try to get as great an AP spread as possible. And also placing implants further distal preserves bone at distal sites, which is nice. But I think quite often in the maxilla, if we want to get greater AP spread, we're going to have to do some type of sinus procedure or some type of angled implant. So because we have the hard palate, the appliance is going to be resting on the hard palate. And I always cover the anterior third of the hard palate. We certainly don't need a post-am. We don't need to cover the entire hard palate. But if we've got at least that anterior third of the hard palate covered, AP spread becomes less significant in the maxilla, not in the mandible. In the mandible, I'd like to have it for sure. But and then some of the other factors we're going to look at is if I've got a patient with a very flat palate, I'm going to want greater AP spread on my implants because I don't have any resistance to lateral forces. Somebody who's got some palatal vaulting, I'm not as concerned with AP spread because I can cover that palatal vault usually with a metal frame. So my maxillary overdenture will have a metal frame, and that will help resist lateral movements. But AP spread in the mandible is very significant to preserve bone at distal sites and prevent and act as an indirect retainer as well.
And from a periodontal standpoint, going back to the case you have up, the importance of obviously plaque control of inflammation, compliance therapy from a standpoint, water pick, as well as having the patient come in more often. patient like this, I would see every 2 months until they could get everything under control. Definitely using a water pick, be suggesting something like sodium bicarbonate or Clorox bleach diluted is something that I would use routinely in these cases. Definitely diluted. Usually around a half a teaspoon to about 8 ounces of warm water, and rinse and use in a water pick. Okay.
And I think the other problem, I'm not showing the old prosthesis, but it was acrylic, and it had concavities. The fixed restoration was full of concavities. So even if the patient was trying to maintain it hygienically, it just had wells where bacteria were hanging out.
And that could be due to lack of restorative space, or the laboratory not being, on board, because that could be corrected, obviously, by the restorative dentist if there's adequate room, if this person came as a second opinion to another dentist, and then that's something can be solved frequently. So
but you got to get them out of that appliance and start cleaning it up.
So I think we covered this, but if you want to just touch on it again, how often have you had a transition removable to a fixed in your practice, would you say?
Removable to fixed is about 40% of the time in the maxilla. And I think it would be higher, except that a lot of my overdenture patients are in their 80s, and they're not interested in spending the cost and all that. But my younger patients, and this is Andrew, and Andrew's in his he's like 70-ish. He had, so 40% of these patients do transition to fixed. So this is a patient who came in new to my practice, and he had an overdenture, maxillary overdenture, well made metal frame. It was really well made. And the reason he came in was his inserts were wearing out. He wanted more retention. And I just casually said to him, and if you look at his lower arch, he's got an FP1. This is an implant supported fixed restoration. So I casually said to him, why didn't you do a fixed bridge up top? I see you did that on the bottom. And he said, oh, I didn't know I could. And I'm thinking like, that's kind of odd. So the first thing I did is I measured his appliance. I took an old school Bowley gauge and just measured the appliance, and I had 14 millimeters of space. I mean, and there's a lot of wear on that appliance, so I have to open them up anyway. So if I've got 14 millimeters of restorative space and I'm going to open them up due to the wear on that teeth, and more importantly, maybe most importantly, look how healthy those implants are. This guy proved himself to be fastidious with his hygiene, and they've got adequate buccal bone, and the angulation. Look, the locators, the angulation's not bad. We did take a CBCT, and we had minimum 4 millimeters of buccal bone. There's no reason why this couldn't be a fixed case. So I said to him, I said, you know what, we can get rid of, because he was complaining about having to replace the inserts so often. So I said to him, we can solve that by going to a hybrid. So he's one of the 40% that transitioned from an overdenture to a fixed restoration, and just using those 4 implants on him.
It's important to discuss with these patients. We've talked about it, Briar and Bob and I, regarding where the position of those 4 implants are. The patient obviously can afford an FP1. He wants to go fixed. Not a bad situation where you may want to consider, if we have enough bone and so forth, to go with at least 1 or 2 implants anteriorly. And if there was parafunctional habits, is 1 implant posteriorly on either side, so there wouldn't be a cantilever. So, if money wasn't an issue, you could put in 6 implants very easily with this guy and have a really good long-term solution. Discuss about the restorative on the intaglio surface. I think that's important.
So, your comment about 1 or 2 more implants is wonderful, because if we had another implant in the lateral, this is sort of first bi, this is sort of distal of the cuspid. If we had another implant in the lateral sites, of course, it would give more support, but it would also give us, it would decrease that pontic span. And that's my big concern. We all love zirconia. Zirconia is the most biocompatible material we have, with the lowest plaque affinity. So it has the greatest resistance to highly polished zirconia. Has the greatest resistance to plaque because it's monolithic. There's no porosity versus acrylic or something like that. So, but the downside, going to Bob's question, the downside of zirconia is it's a very rigid, brittle material. So the critical factors when we design a hybrid is, of course, we don't want to have concavities. We want to have convexities. But what you'll see, what we did in this case, because we only had 4 implants, we've got distal cantilevers, bilateral distal cantilevers, and a large anterior pontic span. The laboratory incorporated a milled titanium frame to support. So there's no unsupported zirconia, which could fracture. They made a milled titanium frame, and then the zirconia was just luted on top of that. So I feel that, and it's been in the mouth for 3 years now, I feel that we've got adequate support in the distal because we don't have implants for the distal. And we've got adequate support to that pontic span, although going back to your comment about 2 more implants, that would have been ideal, without a doubt. Yeah.
Brian, what are your thoughts about treatment planning in this case, if this case came to you at school to redo, to go to a fixed?
So I think he's taking great care of his implants, which is great. And if he's interested in doing fixed as well, like that's an incredible option for him. I would consider, depending, I think with an implant retained overdenture, we do have improved chewing efficiency than a denture. However, we do know that we do get increased chewing efficiency with an implant supported fixed dental prosthesis. So I would consider maybe eliminating one of the premolars and making it a little bit shorter, so we don't have quite as much of a cantilever if we are doing the milled bar, or having that as a potential option as well.
Yeah, without a doubt. Yeah, to minimize those cantilevers. This, I actually saw her today at a hygiene visit. So Mary had come in. Yeah, she had come in with an overdenture, mandibular overdenture with an old hater bar. I mean, I don't know who, I'm sure nobody still makes these, but it was a cast gold hater bar.
We made these for years. They were great.
Oh yeah, they were great. Except this one broke 3 times and had to be soldered.
Why don't you tell the audience about the ability of replacing them?
Of replacing hater bars?
Or the ERA attachments.
Yeah. I mean, I think today I would just remove that bar and put 4 Novaloc full locators in there. But yeah, these had 3 hater clips, the little yellow hater clips, and 2 distal ERAs. And that was pretty much, that was our design back in the 80s and 90s. And they're a bear to replace. But so going back to Breyer's comment about the shortened dental arch, or minimizing your cantilevers, I spoke to Mary about going to something fixed instead of replacing that bar with attachments. And what we did was a shortened dental arch. And the only thing I would have liked to have done was, rather than a bicuspid, put a molar back there. But we eliminated 1 bicuspid essentially to minimize the cantilevering. Otherwise, she would have really needed another implant for the distal. So we do treatment plan shortened dental arches on our fixed cases. Yeah.
Yeah, as I mentioned, no one's ever died from a premolar occlusion. So patients do very well with that. So.
Yeah. And also leading into that question, or adding to that question about transitioning from removable to fixed, when we treatment plan any removable patient, and this goes to what Breyer just said as well. Here's a patient who's going to be fully edentulous in the mandible. They're partially edentulous now. They've had significant super eruption of the remaining teeth. This was combination syndrome with upper denture and super eruption. So we're treatment planning, whether this is going to be fixed or removable, we're treatment planning this as a fixed case with 4 implants. Going as far distal as we can. We could have gone with angled implants and gotten a little further distal. Even though, so we're treatment planning as traditional hybrid, even though this patient wound up going removable, and we knew from the start that she wanted to go removable, we still treatment plan it as a fixed case because 40% of these patients transition to fixed. So when, I won't even say if, I'll say when she comes back and says, okay, I want the permanent restoration, we're going to place another implant in those just anterior to that mental foramen and go to a fixed case there. So we do always treatment plan with that in mind. And of course, we've got a nice AP spread on these three, but a beautiful AP spread if it goes to a fixed case down the road. I think I answered your question.
Yeah, one more thing with this is I see some like teeth that appear to have a like relatively healthy periodontium. And if we are able to, in some cases, save some of the teeth, is there any way, or if we don't have so much of an occlusal discrepancy as we do in this case, but if it's more of an even plane and we have a couple of teeth, but they're not in the right location for us to be able to have a fully implant supported or implant retained prosthesis, is there any way we can combine teeth and implants in a removable prosthesis?
Yeah, without a doubt. You know, I think, and I've probably been guilty of this myself in the past, is we look at a patient who's got a couple of healthy teeth, they've got good bone, good periodontal support, and we say, well, they're in the way. Those teeth are in the way. I'm looking at these patients totally differently now, and something that, and I guarantee most dentists are not thinking of this, and I didn't think about it for the first 20 years of my practice, is I make a fair number of implant retained partial dentures. So this is not a full arch restoration. These are, and most often they're class plus, like you see on the upper left. And the beauty of an implant retained partial denture is that if we have a patient who's got some healthy teeth, so this patient, the 6 anteriors, she's got some parafunction, but there's no mobility, there's no real bone loss at all, some ab fracture, but she fractured this bicuspid, and she came to my office for a partial denture. She knew she was going to need a new partial denture, and I spoke to her about getting 2 implants, first molar with a 3-unit bridge on each side. And she just, cost-wise, she said it was prohibitive. She couldn't do it. So what we did is we certainly, I didn't want to make her a traditional partial denture. She'd wind up fracturing the rest of the teeth. So 1 implant was put in on either side, and we're combining implants and teeth, where so we made her an implant retained, not implant supported, but an implant retained partial denture. And we're using, of course, the major connectors is getting its support from the hard palate. We're using those teeth as guide planes. We don't need clasps. We have adequate retention from the implants. So we're using them as guide planes. We're using them as indirect retainers. And something that you've mentioned in conversations we've had in the past is we're going to maintain the proprioception. So by having natural teeth. So implant retained partial dentures, even in a situation like this, where this guy just didn't want to give up those last 2 teeth. We were talking about an overdenture, we were talking about a hybrid. He was not going to give up those 2 teeth. So implant retained partial denture, where here we do have class. So if we've got implants on one side of the arch and no implants on the other side, we get our retention on the other side of the arch from clasps and our reciprocation. So I think we really need to consider implant retained partial dentures as an option that's quite often overlooked.
And when there's 6 teeth, and like the case, I think the slide prior, Bob, if you go to, I mean, the major aesthetic benefit, we don't have to clasp 6 and 11. Could you comment also the position of those 2 implants and where you would prefer to have those placed?
Okay, so I know you're asking that question because we screwed up on planning this case. So what we should have done,
this isn't my case. So.
What we should have done, if you look at the one of the ITI, this was the ITI treatment guide 3, I think, was talking about partially dentless patients. What we've come to realize from finite element analysis studies and from clinical trials, that you're 100% right. So those implants, rather than being placed directly behind the teeth, those implants for an implant retained partial denture, which this patient, the Panorex you see here, is going to be getting a maxillary and mandibular implant retained partial denture. Those implants should be placed as far distal as possible for many reasons. Number one, we're going to preserve bone in distal sites. That's nice. The second reason is we're going to have indirect retention. Now we're going to prevent rotation or dropping of that appliance. And then, of course, it also allows us to transition to a fixed fixed bridge down the road. So with that, it's a wonderful point you bring up. Yes, even if you look at this middle diagram, by moving that implant distal away from the teeth, there's much greater benefits. So now, if we go back to that previous picture, in retrospect, these implants really should have been placed in the second bicuspid position to give us more bone preservation distally. We could always go first molar, second bi, with a mesial cantilever for a fixed bridge if we wanted to go fixed down the road, and we still would have had the benefit of just basically a guide plane on those teeth without clasp. We would have had adequate retention. So yes, I think this Panorex really brings home how we should move them as far distal as possible. And
too often on Instagram, I see all of these teeth taken out, and all on fours. And teeth are not lost to periodontal disease, as P.D. Miller likes to say. They're lost to titanium frequently. So this would be a case that we'd see all on four. They don't show any x-rays before. But this person has these teeth and can keep these teeth the rest of their lives.
Yeah. Well, going back to Breyer's question, look at the bone support. We've got beautiful bone, beautiful periodontium. And this patient. Yeah. And we're going to maintain proprioception. So, I mean, he's got a lot of wear. He's a clencher grinder, but without those teeth, who knows what he'll do to the implants with his bruxism. So, implant retained partial, wonderful option that we just don't talk about. Now, one other way, and I don't want to spend a lot of time on this, but one other way of combining implants and teeth is to go back to the old Mort Amsterdam and Walter Cohn theory of the periodontal prosthesis, where everything gets a coping, every tooth got a coping, and then the bridge work would slip over the copings. Well, there's absolutely no reason why, now that we have the conus technique or the coping crown technique, why we can't have custom abutments with copings that fit on top of them and combine them with teeth. So we can have teeth with copings, implants with copings, and a removable appliance that gives us secondary splinting to slip right on top of that. So what I'm showing in this picture is 4 implants, a horrific angle. I mean, just crazy angle to these implants. They're coming out our nose, but with 4 custom abutments, and then curing those copings into the appliance, and we certainly can combine teeth in here. We have secondary splinting, meaning not a bar, primary splinting, but secondary splinting of teeth and implants together through the conus technique.
So what are the indications for overdentures? Actually, overdenture bars. And I think you have a really fine joke to talk about overdenture bars. So you share that with us. We appreciate it.
So overdenture bars, we have to appreciate what overdenture bars do. But Bob always asks me to tell my overdenture joke. So, and it's actually a true story. It's about 10 years ago, I was teaching at University of North Carolina. I was teaching an undergraduate overdenture course. And Lyndon Cooper was the head of the department at the time, and he asked me to come up with test questions. And one of the test questions for the undergrad students was, why do we have overdenture bars? So that's the question. Why do we have overdenture bars? And I'm looking for the answer of correction of angled implants or coarse arch splinting of implants. And one of the students wrote down, question is, why do we have overdenture bars? One of the students writes down, so edentulous people have a place to meet other edentulous people. True story. Think about it. It's funny. But from a private practice, from a real practice standpoint, why do we have bars? Bars do 2 primary things. They give us correction of angulation. So if I've got a patient with implants that are and I very rarely make a bar in the mandible, usually the maxilla. So if I've got significant angulations to those implants, I can't even correct the angulation with a locator or a Nova lock, which I know we can correct, 20 degrees, but not 30, 35 degrees. Well, I don't want to place a overdenture. I think of all the lateral forces that are going to go on those implants. Or if we've got a patient who's got inadequate buccal bone, and I'm thinking, wow, they could just push those implants right out of the buccal plate. The beauty of a bar, if it gives us cross-arch splinting and correction of angulation. So whenever I get a patient referred to me that I'm looking at these implants on a crazy angle, inadequate buccal bone, and I need to correct the path of insertion, I want to splint them, that's what a bar does. So it aligns our path of insertion, it shares the force. Now we've got cross-arch splinting. And even I would say the third thing, in addition to angulation correction and cross-arch splinting, is the patient who's a real Brooks, a real parafunctional patient in the maxilla, I feel better making a bar, splinting those implants together. So if we look at this, we're looking at, and now we're talking about implant retained and implant supported. So where a traditional overdenture is implant retained tissue supported, with a bar we're implant retained implant supported, because we, much like a hybrid, we've got cross-arch splinting, everybody's together. And the only thing I would say in addition to that in the prosthetic design is I always put a metal framework. When I'm making a bar overdenture, I always put a metal framework in there because I don't want the patient to fracture the appliance. So 2 examples of bars. And I want to show you one patient really quick who had been wearing a maxillary partial denture for years. And this anterior bridge is ready to fall out. There's recurrent decay, there's fracture. I mean, there's nice bone, but there's inadequate. I mean, the restorative is gone. So everything would be sheared off subgingival. What we wound up doing with this patient was 4 implants in the maxilla. And this is the slide I showed earlier. But the surgeon who placed these implants put them on about a 35-degree angle, and inadequate buccal bone. I wasn't feeling very good about this case surviving with 4 individual attachments. So we made him a bar. And remember, we talked about an overdenture needs a minimum of 8 millimeters. A bar, you need 12 millimeters of restorative space, which is why I'm holding a rule. This was back in the Stone Ages before we were scanning. That's why there's stone there. But that's why we have 12 millimeters. And then of course, when the bar is milled in the lab, they just mill the thread for either a locator or an overlock abutment, which is nice because if these wear out over time, you don't even have to replace the bar. You just unscrew the attachment, screw a new attachment. They're about $65 a piece, screw a new attachment in. So that's our answer to overdenture bars. He had everything going against him: angulation, inadequate buccal bone, bruxing. So a bar, and this has been 14 years in the mouth without any problems.
Well, I think it's a good place to stop and open things up for questions for the next, hopefully 5-10 minutes if we can.
Yeah, we did have a question.
I'm sorry.
We did have a question about the implant overdentures and picking up locators. Someone was asking, Will was asking if you pick them up one at a time or all 4 at the same time.
Okay, so for years, I always talked about picking up 1 or 2 at a time because of the fear of locking the overdenture in the mouth. Today, I pick up all 4 at once, and I'm not worried about locking them in the mouth, which I'll tell you why in a minute. But the reason you want to pick up all 4 at once is if you're curing in 2 and the patient's biting down, you're curing in 2, what's going to happen is when you go to cure the other 2, you're going to see some unequal seating of that, or you're going to see some movement to that appliance. So you want equal pressure, patient-centric, not killing it, just, a little mucocompression, and you want to cure all 4 at once. Now, if one of them doesn't cure in, it's not the end of the world. You roughen it up and you cure it in. And of course, so definitely all 4 at once. The big fear is that you'll lock it in the mouth. And if I always say, if you've never locked an overdenture in the mouth, then you've never made an overdenture. So, what I do now, and I haven't locked an overdenture in the mouth seriously in probably 15 years, is I don't use acrylic. It's the worst material to cure housings. I only use composite. There's several materials out there designed for curing housings in overdentures. And most importantly, I always put a vent hole in my denture well. And I think I have a picture of this. Yeah, if you look at this bottom photograph, the two bottom photographs on that slide, I'm getting ready to cure these 4 housings into the denture. I always put a vent hole. And the reason for that vent hole, the critical factor for that vent hole, is that when the patient bites down, you're going to have air in that denture. You're going to have composite in that denture. It needs to escape somewhere, and it's going to look for any undercut. With a vent hole placed in the middle of that well, as you go to seat that appliance and then the patient bites down, the air is going to escape, the excess material is going to escape. And I haven't locked an Ovidenture in the mouth in probably 2 weeks. No, seriously, I haven't locked an Ovidenture in the mouth in years. And I did my own little unofficial research on this. A number 10 round burr is the ideal diameter in order to give an adequate vent hole for materials to flow out of there. So that's it. Vent holes and no acrylic. Use composite.
Jim, any questions from the audience that we want to address?
Okay. Why do you mix the attachments in the, okay, so the question was, why did I mix the attachments in the last case? So the attachments each attachment has a different amount of retention. So let me get to a more ideal case for that. Oh, here's one. Okay, so I can show a better one. So each insert has a different amount of retention. So if I have a patient who says, well, you know, when I bite down anteriorly, it trips, what I'll do is I'll put a more retentive insert in that distal. But I don't like to put the highest retention in right away. I usually start with a low or medium retention. And then also as the abutments wear over time, I'll mix and match. I've had plenty of patients that say, I can't get the right side out. They can get the left side out, but not the right side. So I'll put a lighter retentive nylon insert on the right side, and it's fine to mix and match. There's no reason why you can't mix and match.
How many retentive colors are there now, Bob? How many are there?
So interesting, in the locator, there's 5. In the Novalock, there's 6. Novalock has a split ring design. And this is, let me see. Oh, shoot, I thought I had a Novalock case in there. So the Novalock has 6. And the bottom line is that you get used to putting in and what the patient's comfortable with. I want to try to find a Novalock. And usually I'll start with the lightest or medium. Here's a patient. So here in this patient with the 3, I have 2. These are locators. I have 2 blue in the distal. Blue are higher retention, and I have a pink in the anterior because I wanted the patient to be able to pop it out. If you look at the upper left, those are the Novalock, the split ring design, and there's 6 different levels of retention. But I'll tell you, with those 6 different levels of retention, don't ever use the highest level, because you just can't get it. You got to take a crown and bridge remover to get it out. So I limit myself to the 5 and not to 6.
How often are you replacing these inserts? Patients always would ask.
Okay, so I tell patients that, well, I actually changed what I said, because when I was using locators exclusively, locators are a wonderful attachment, and I still use locators, but I've transitioned more to Novalock. I tell patients with locators that the nylon insert has to be replaced every 7 to 8 months. Some patients, and I know it's closer to 8 or 9 months, but I tell them 7 or 8 months. And then some patients will go through them in 4 or 5 months, and some will go 2 years. But I'll tell you that this is a critical clinical trick that I found. The patient that's going through those inserts every 2 months, they're showing up every 2 months. They say, it's loose again, I need new inserts. I guarantee you that appliance has become implant supported, that it needs to be relined, because every time the patient bites down, it's no longer tissue supported. Every time the patient bites down, they're pancaking out those nylon inserts and they're beating them up. The patient that comes in, you look at that insert and it looks like somebody just cored out the center of it. That appliance, you need to paint pressure indicating paste on there, have the patient bite down, and 90% of the time they need a reline, and that's why they're beating up those inserts so quickly. Novalock inserts I replace about every 14, 15 months. They do last longer because of the split ring design.
Great. And we had another question too about your about implant overdentures on the mandibular arch, and how one of the questions was about having them in the lateral position versus like canines or something. And they were wondering, like, isn't that decreasing like the amount of AP spread? So can you just elaborate a little bit on how you're getting your support from other, or retention, excuse me, from other areas as well?
Yeah. So if we look at the left-hand side, this, I'll call this the lateral position, as opposed to the lower picture would be the cuspid position. You're trading AP spread. Actually, there really is no AP spread here because we're talking about just 2 implants. So by going to the lateral position, what you're doing is you're going to minimize your rotation, your anteroposterior tripping. If we were talking about 4 implants like you see over here, then my 2 distal implants, I want as far distal as possible to increase that AP spread and preserve bone at a further distal site. So the AP spread doesn't really apply to 2 implants, but certainly to 3 or 4 implants. And yes, if you look at this middle picture down here, we got as much AP spread as we could, but that requires 3 implants in order to do that. With just 2, being back to the lateral. I see there's a question about border mold. Do I border mold for my overdentures? And the answer is definitively yes. An overdenture is a denture. It's still a denture. It's denture occlusion. It's, try to keep bilateral balance, try to keep as flat plane as possible. It's still a denture, and you do have to border mold because
it's tissue supported, as you mentioned, Bob, many times. That's really important. So.
Yeah, I almost would like to say it's a denture with implants underneath it. So you do have to border mold. Yeah, and one of the reasons, I like to say I'm 100% digital in my practice 90% of the time, because when I make an overdenture, I still use polyvinyl for overdentures. And I know Charlie Goodacre talked about scanning for overdentures. But I'm still, my one holdout is overdentures. I still do polyvinyl and border mold.
Okay. Any other questions?
Oh, experience with locator fixed. Yeah. So there's a new technique out called locator fixed. I've only done 4 cases, so I'm certainly not the world's expert on that. What locator fixed is you're going to use traditional locator abutments, the original locator abutment. They call it the legacy abutment, the ones that you see that I was showing, like these down here.
Yeah.
And the retentive cap, the nylon insert and retentive cap, is designed to not be removable. So what happens is you're going to cure your housings into the denture pretty much the way you would for an overdenture, but then the nylon insert that goes inside the housing, it's a different housing as well, but the nylon insert that goes in the housing has such a friction fit with that locator abutment that it becomes a fixed appliance. The patient can't remove it. We can remove it, but it requires us tapping it out with an instrument to do that. So my experience has been okay. I've only done 4 cases. The only downside I've seen so far is one case I made a zirconia hybrid and did locator fixed, and I could not get a predictable bond of the housings into the zirconia. That was my only downside.
Any other questions? So I think that ends us for tonight. So I want to say thank you again, Bob, for joining us, and Briar for co-hosting with me. Our next meeting will be June 12th. Our hot seat candidate will be Bak Lee from USC, and with my co-host will be Ismail Cooley. So I want to say thank you from all of us. We appreciate you all watching, and we'll see you next time with Bak Lee on June 12th. Have a good night.
Thanks, guys. Briar, Bob,
thanks, Briar.
Thank you.
Take care.
Good night.